Dr. Vishakha Sangewar. Dr. Vishakha shall be speaking on the diagnosis of tuberculum sella meningioma confounded by glaucoma.
Good morning, everyone. A 66-year-old female patient, homemaker by occupation, came to the OPD for refraction and routine glaucoma follow-up. On clinical examination in right eye, best corrected visual acuity was 6.9 and 6, anterior segment within normal limits with grade 2 nuclear sclerosis. Intraocular pressure was 15 millimeters of mercury on Goldmann applanation tonometry at 10 a.m. Fundus examination showed normal size disc with 0.3 vertical cup disc ratio. Foveal reflex was present and periphery within normal limits. In left eye, best corrected visual acuity was counting finger half meters, n less than 36. RAPD was present with grade 2 nuclear sclerosis and intraocular pressure was 14 millimeters of mercury on Goldmann applanation tonometry at 10 a.m. Fundus examination showed normal size disc with disc pallor and 0.3 vertical cup disc ratio. Foveal reflex was present and periphery within normal limits. Previous systemic history showed patient was hypertensive since 10 years and history of carcinoma breast, for which she was operated and received chemo in 2016. Patient was diagnosed to have primary angle closure glaucoma in 2019 at routine ophthalmic checkup. Both eye laser PI was done and she was started on anti-glaucoma medications for optimal IOP control. Perimetry was normal at that time and left eye OCT RNFL showed a superiotemporal wedge defect. This is the OCT RNFL of the left eye in 2019. A regular follow-up was advised, but patient didn't report till 2022 because of pandemic. In 2022, she complained mild reduction in left eye vision with right eye best corrected visual acuity 6.9 and 6 and left eye 6.18 and 6 with intraocular pressure 14 in both eyes. Significant pallor noted in left eye with defective color vision. Left eye AION was suspected. She was advised a physician review and follow-up perimetry, but she did not report. Patient next reported in 2024 with further diminution of vision in left eye. In right eye, best corrected visual acuity was 6.9 and 6, and in left eye, counting finger half meters, n less than 36 with left eye RAPD. Dilated fundus examination of left eye showed significant pallor with minimal cupping, and right eye showed minimal pallor. Perimetry of right eye showed depressed areas in nasal hemifield, and OCT revealed widening and deepening of the RNFL loss in left eye. Right eye remained normal. In view of significant pallor, RAPD, and progressive loss of vision in absence of any other documented fundus pathology, MRI orbit and brain was advised. MRI brain showed large tuberculum celli meningioma with clinoidal attachments. Conclusion: concomitant neurological pathology should be suspected when there is disparity between disc changes, visual acuity, and visual field loss, especially when associated with RAPD and color vision defect, after ruling out confounding ocular lesions. Thank you.
Yes, that was a nicely documented case, Dr. Vishakha. It's always important, especially in the cases of bilateral temporal pallor. If you see the way, in your clinics, always such patients should be subjected to Humphrey perimetry. You will not be surprised. Many times they end up with getting hemianopias and other neurological deficits. So it's a very important sign. You should never ignore bilateral temporal pallor also. This case specifically you demonstrated in one case this thing, but any specific pallor like glaucoma, the presentation is somewhat different. There is cupping, there is focal defects, there is notching, everything, but the rim remaining normal, but only the presence of pallor. You should always subject these cases to MRI. Okay? Thank you.
Thank you,
Well done.